saturations for unexplained reasons and for all different reasons. Many of these babies were kept with too much oxygen. And then you see the baby next to this baby, he's desaturating. He has alarms going off at 75%, 60% all the time. So these babies are going from one extreme to the next. And it's a problem because either they get too much or too little. So we thought of ways, and this is in the year 2000 or earlier, we were thinking of ways on how to improve the care of these babies. So this is very much what we are trying to do. We're trying to maintain this balance between excessive oxygen versus too little oxygen, because we know that too little oxygen can be as bad for different tissues. But we are also aware that these babies have some respiratory instability. There is a reason why these babies are on a ventilator or on CPAP, and there should be a reason why these babies are receiving supplemental oxygen. They have some form of lung disease, and therefore these babies have some form of respiratory instability. So they are receiving oxygen, they are receiving respiratory support, and a number of other things. But what we always questioned was, how was the policies of the institutions of the different newborn intensive care units, or how were the attitudes of the caregivers, the nurses, respiratory therapists, residents, fellows, affecting those outcomes, or at least affecting the stability of oxygenation. And it's probably very much dependent on the caregivers. This is what I call prolonged oxygen exposure, and this is from infants that were born in our institution and in the University of Miami. This is the percentage of babies that were still receiving oxygen at different postnatal weeks. And you see how babies that were born between 24 and 25 weeks, even after 14 weeks, about 25% are still on supplemental oxygen. By this time, many of these babies have been already classified or considered to have BPD. But you see that the exposure in general is prolonged, so there is plenty of time to cause damage. So it's not only the risk, but the risk is increased because you have plenty of opportunity to cause the damage. Again, this is the slide I showed you before, and your eyes probably went to the 70%. Okay, and you always wonder whether this center actually had babies that had saturations of 71, 72, 73%. But these were only the alarm settings. They targeted this, or they set the alarm here, to avoid their nurses to jump every time the baby had a spell of desaturation and increase the oxygen and walk away and take care of the other baby. I don't know how many nurses per patient you have in your unit, but it should be how many patients per nurse you have in this unit, in your units. And their nurses are very busy. So most likely what they were trying to prevent is the excessive oxygen response, the excessive amount of oxygen these babies get when these alarms are going off. You have seen this slide before, so I'm not going to repeat, but you see by 14 weeks, a baby that was born on 24 weeks is already considered to have bronchopulmonary dysplasia. So this targeting has an important effect not only on the evolution, but also on your statistics. So if you want to lower your rate of BPD, you targeted lower saturations, you're going to end up giving less oxygen to these babies. Now, these two trials I commented before, 47% versus 37%, had still require supplemental oxygen, and the 64 versus 46% when these babies had been kept with saturations over 95%. So in these two studies, babies were kept with saturations over 95%, had bad pulmonary outcome. So how bad was this oxygen, how much more oxygen these babies were given. In the boost trial, these babies spend over 20% of the time with saturations over 98%. So imagine spending more than 5 hours a day or 6 hours a day with saturations over at 99 or 100%. So these babies were receiving, or were supposed to be receiving, a lot of oxygen. But you see, this trial, the stop-drop reported that by 24 hours, the FiO2 was increased only by 10%. So 10, 15% difference was enough to keep these babies, and many of these babies, with very high saturations. Okay? And that was probably what was causing the lung injury, the poor respiratory outcome that these two articles describe. Okay, so it's not only that they were targeting a higher saturation, but they were spending a lot more time in the very high saturation range. And the only way to get there is by giving a lot of oxygen. Now, what is the reality today is probably different than what we think it is. And this was shown by these investigators, that if you prescribed a range, if you walk to the unit and you say, I want this baby to be within 88 and 94%, and you come back the next day and you actually count the time that this baby was between 88 and 94%, most of these babies would spend only half of the day, 12 hours of the 24 hours in the range. The rest of the time, the majority of the time, unfortunately, they would be above the target range, about 1/3 of the time. So 8 hours of 24 hours, saturations are over the range that you as a physician prescribes. And about 20%. You have another point. And about 20% of the time they spend with saturations below the 88 or the range that you prescribe. Thank you. Okay, so where is this information coming from? This was obtained from 14 centers, all babies born at less than 28 weeks of gestation. They were all receiving supplemental oxygen, and this is the data for each individual hospital. And this is the time these babies spend within the range that the neonatologist wanted to be. This is the time below, and this is the time above. You see how some of these centers had very long periods of time, or these babies spend very long periods of time with saturations over the prescription. And some of these centers also had very long saturations, very long periods with saturations under the range. And probably a good part of it were on very low SATs, probably under 70%. Okay, so there is a wide variability between centers, but now some centers that had kept the SAT alarms, the alarms on the monitors, very close to the prescription, to the prescribed target, actually had better outcomes or better times within the range. You see, it's more consistent between the different units, and this time within the range is greater than the two. Okay, so probably the policy in each of these centers, how concerned they were on keeping saturations was very important, because it made somewhat of a difference. You see, these centers spend more time with saturations in the range. Okay, but it's not so easy. You see, this is the 48% in all 14 NICUs. These NICUs that have tight alarms, only 1 or 2% lower than the target. So if you wanted to have the baby between 88 and 94, you keep your alarms at 87 to 95. Very close, very strict. And that's how they actually improve the time, 53 versus 42%. But also, they notice that as they get older, these babies spend less and less time in the range. As they get chronic, as the lung disease evolves from the typical HMD to the chronic lung disease, these babies end up being more unstable. And this is contrary to what you expect. They are not as sick as before. They are convalescent. They don't have the acute lung disease anymore. And this is typical. The baby that is desatting, that is going up and down all the time, is that baby that is probably on low settings on the ventilator, that is moving more. He's probably on CPAP or extubated. He's not as sick as before. Babies, when they are very sick, generally they are sick all the time. They are not up and down. These are babies that have some form of evolving lung disease, some already chronic lung disease, and you see how by the week, by postnatal week 4, actually they spend less time within the range. And this is typical. The babies that desat are those chronic babies. So what are the roles of the alarm ranges in the SAT monitors? And this is very important. And from these 14 centers, each reported the average saturation on each center. And I plotted these values here. This is the mean saturation, and this is the low saturation alarm on each center, and this is the high saturation alarm. And you see the contrast. This is the low alarm on each of these centers. You see that there's not much of a relationship. But when you see the high saturation alarm, you see this is 92, this is 94, this is 96, and 98. So they are very, or a lot more correlated. It means that whatever you use as your high alarm is very likely to determine where the babies are going to be kept. So if your high alarm is at 96, most likely most of your babies are going to be around 96. Okay, so the determinant factor, or where is going to be these babies, are essentially going to be determined by the high saturation alarm. So this is very important. And this is how you have to determine what is the best policy for your center. Okay, now you determine what is the alarm that you want to keep. You want to keep the alarms at 94 or 95 or 93%. You decide that based on the consensus between all the caregivers in your unit. But then you monitor how is the progress, how compliant is the staff to these alarms. Unfortunately, that is a big problem. And this was documented by these investigators in Australia. The low alarm should be at 85%. And you see that the low alarm, in most cases, it was maintained at 85%. But the high alarm that should be kept at 94%, it was kept only 1/4 of the time. The rest of the time, it was always moved up for many reasons. The most common reason is because the baby was on very low